All right, I am going to keep chugging on because this topic generally takes kind of a 2 days worth of Esquilitas. So I'm going to try and see if I can get ahead a little bit. I'll probably go just 5 minutes past the hour, just get a little bit um, behind us. Let's talk about minimal change disease before we go into FSGS. Okay, now hopefully you know that if I have a child with nephrotic syndrome, minimal change disease is the most common, most likely diagnosis. Okay. Now, if I have an adult with nephrotic syndrome that doesn't have diabetes, lupus, or any other obvious, secondary cause, we call those idiopathic nephrotic syndrome. They can have minimal change, they can have membranous, and they can have FSGS, right? Those are the most likely diagnoses in that context. Okay. But we see minimal change in adults. I mean, that's all I see. I don't see kid minimal change disease. And that can happen in about 10 to 15% of these patients that have no discernible cause of their nephrotic syndrome in an adult. Okay. Now, if I have an individual who is Black, the most common diagnosis is FSGS. So in these non-Black populations, then you can say that the likelihood of membranous is still more common than minimal change disease, but minimal change disease is another distinct possibility. Now, minimal change disease is typically idiopathic and happens without any inciting event. However, there are some secondary disease associations. These are also cataloged in that chart that we started with in the intro to GNs. Okay, so this is a recapitulation of some of those things. Non-steroidals are associated, okay, as with membranous nephropathy. Okay, some people say this association with membranous with nonsteroidals is pretty iffy, but clearly there is an association with NSAIDs and minimal change disease. Classically, these patients who have minimal change disease from NSAIDs can also have interstitial nephritis. So that's well described. Nonsteroidal induced interstitial nephritis with minimal change disease. Okay, what does that mean? How can those two coexist? Minimal change says, I don't see anything on kidney biopsy other than electron microscopy basement foot process effacement and in the podocytes, right? Well, these individuals will have interstitial nephritis on light microscopy, and they also have diffuse foot process effacement on EM, but the light microscopy of the glomerulus looks normal. Okay. This is associated with penicillamine and tiopronin. However, the much more likely association with these drugs is with membranous nephropathy. There's an association with lithium, bisphosphonates, interferon, although those are more commonly associated with FSGS. We'll see these again when we talk about secondary disease associations with FSGS and membranous. Sulfasalazine and these drugs that are typically used in inflammatory bowel disease have an association with minimal change disease. And then there are these rare associations, which I would be suspicious of. Okay, maybe guilty by association, but not truly an inciting event. Okay, those are the drugs. Cancer has an association. We had a patient he's passed away, but we had a patient in GN clinic who, as a first, I think actually it was Naveen who asked about this, as his first manifestation of recurrent Hodgkin's, he had new onset, or he had relapsed minimal change disease. There are other malignancies that are associated. Thymoma is associated. Renal cell carcinoma. We have another patient who has minimal change disease, and she was interesting. She was steroid responsive, but then calcineurin resistant. That doesn't make sense. She was the only patient I've ever had that was steroid responsive, but calcineurin resistant. And so, she ended up having a renal cell carcinoma and we ablated that, and now she's calcineurin. She became calcineurin responsive. Okay, that was an interesting one. Infections are associated. HIV is clearly associated with it. Hep C, syphilis. People have described COVID associations now. However, we typically think of collapsing FSGS as associated with HIV and COVID. And then in the literature, there are these associations with bee stings and allergic flares, and even with immunizations. And that, I think, is a pattern of disease that is more manifest in pediatric nephrology. I've never seen an adult with minimal change after a bee sting or even an immunization. Okay. Pathology. Yeah. Well, no. So that's a good question. There's a fair amount of similarity in the features, right? But by definition, if I'm seeing a lot of, immune complexes and full house staining and tubular reticular inclusions, I'm not going to call that minimal change disease. I'm going to call that lupus podocytopathy. Okay, so just so everyone else is informed on what Huzair is bringing up, there is, even though we don't think about this, there's a less common presentation of lupus nephritis where I don't have much or any inflammatory cells on kidney biopsy, and I just see podocyte foot process effacement on the electron microscopy. And then these patients have an underlying lupus, and they typically have immunofluorescence that is present on the GBM. Although in the reported case series of lupus podocytopathy, they did not require the presence of immune complexes on the glomerular basement membrane immunofluorescence and electron microscopy. Most had it, but they didn't require it to make the diagnosis. They said, well, if you have lupus and you have, this minimal change-like lesion, we're going to call it lupus podocytopathy. Okay, pathology. These, again, look normal, foot process effacement on EM. Now, there is this distinction, okay? I'll end shortly here. There is this distinction between FSGS and minimal change that we're sometimes straddling, okay? It turns out that in order to make the diagnosis of FSGS, I need a single glomerulus in my specimen to reveal a focal sclerotic lesion. Okay, so as you can imagine, what happens if I don't get so lucky? I just happen to biopsy a spot that didn't have areas of focal sclerosis, right? There's focal sclerosis that are present, but I just didn't sample that focally sclerotic population of glomeruli. Well, then it will just look like minimal change on biopsy. Okay. So how do I make this distinction? This is how I would do it. Okay. If you have a steroid resistant minimal change patient, I don't call that steroid resistant minimal change. I basically call that undersampled FSGS. Okay. Minimal change is steroid responsive. It's either non-compliance that would explain steroid resistant minimal change, or it's undersampled FSGS. Okay. All right. Usually immunofluorescence is negative. However, there may be some non-specific IgM deposition. And now, more recently, people are describing these subtle deposits of IgG that may be present. And people are now diagnosing an antibody-mediated FSGS now, okay? They're actually detecting anti-nephrin antibodies in a subpopulation of these patients. It's becoming more and more published in recent descriptions of minimal change disease. People are getting pretty enthusiastic about this, okay? In general, we don't think of it as being an autoantibody mediated condition. However, the literature is growing in describing minimal change disease in some subset of the patient population as in a condition arising from an autoantibody.